good morning to all of you. Thank you, Dr. Jyoti Dev and team for calling me here. Our next speaker is Lona P. Christensen. She's a podiatrist from Denmark. She runs her own clinic and frequently gets patients referred to her for preventing and treating diabetic foot ulcers. As we know, diabetic foot ulcers can cause a lot of morbidity to patients. So early diagnosis and treatment is very essential for them. So I'll pass on the opportunity to Lona to take over and highlight us about the same.
Thank you very much. Thank you very much. Welcome, ladies and gentlemen. Good morning. I just want to say I just been brought in from Denmark. 20 minutes ago, I was in a taxi from the airport. I missed my flight yesterday. But I'm here, and I'm really looking forward to this. So you please, just if I'm missing something and it's going too quickly, it's because I'm a little bit nervous and I don't want to miss anything, leave anything out. But my name is Lone Christensen. I'm from Denmark. I'm a podiatrist and I've been that for 30 years. I'm totally crazy and fond of my work. And I've been treating diabetic people for 30 years. I've got 20 minutes or 15 minutes I had to speak. And I can talk for hours about that. Tomorrow I will be here again, and this session will be of preventive treatment to tell you how to prevent that you get foot ulcers in the diabetic foot. And tomorrow I wanted to help you to treat you how to deal with it, what you can do to provide that. What is it that I will talk about? I will talk about how to take care of the feet. I would how to treat minor conditions and how to prevent complications. This is just facts. We also have diabetes in Denmark, as you can see, and the percent is almost the same as here. The increase of diabetic is enormous all over the world, we know that. And it's not only the feet we have to take care of, it's all the whole body, it's the patient. The agenda of my talk today will take outset in what we call in Denmark the procedure program. This is a program that takes care of the diabetic patient. When a diabetic patient in Denmark is diagnosed with diabetes, this program is started. And now in that, I will also talk about the structure of this foot status examination we do. As I told you, when a patient is diagnosed with diabetic in Denmark, this procedure program is developed. The procedure program is based on a standard that is made out from the government and the Danish podiatrist. And in that procedure program, all the professionals' healthcare is involved. So that means the doctor, the nurses, the dietitians, the diabetic hospital. And we are all here to take care of the diabetic and the feet. And what they do is they put out a referring from the practicing doctor, and the government pays 50% of the treatment in the cost. What is the work that we do? As you can see on the screen, there is 3 different main areas: preventive treatment, treatment of the diabetic foot, and treatment of complications. And I will take it step by step. And the reason why I chose those 3 areas is because this is what we will do to prevent diabetic people having any kind of complications as ulcers. The foot examination is a special, it's classified. It's a structured form that classifies the patients. And we have to fill that in, and it goes to the government. And the government will look into it and will say, okay, the patient will get 8 times a year with 50%. And there's some studies in that form that we have to do. And you can see it here. The foot status involves its examination, circulation, tactile sensitive, joint flexibility, pressure and skin topics, subject experience of neuropathy, and educate, of course, the patient to take care of its feet. First of all, we talk to the patient. We ask them how they are, how long they have the diabetes, if they have any senses, if they feel something in their feet. Example, as you can see the next slide. This is the symptoms we often hear about from the patient. Like walking on cotton, like walking on glass, like burning under the feet. And a lot of people sleep with their feet outside the carpet. And this is the beginning. Then we look into the topic of the feet, how it redness, pleasure, checking out signs of discomfort, such as you can see redness, pressure, skin problems, and other conditions that can relate to complication. We also examine the blood circulation. That's important to have that if you have an ulcer, so it can heal. And it also ensures that the skin is kept healthy, elastic, soft, and as you can see, it's examined by finding the pulse on arteria dorsalis pedis and arteria tibialis posterior. And then we do an neurologic examination. The sensation lack is giving a long term of complication, and we want to be able to treat the patients that they have to look after their feet so they won't have those complications. We also test the joints, and in our process, in my work, I also make insoles for the patient. So that's important to know, how does the joints move? Are they stiff? Are they can you bend them? Because that's also important to prevent ulcers. And this test is just one. What you can see is just one of it. It's described in this form how to do it. And then, of course, we have to educate the patient to take care of the feet. And this is a very good one for putting on cream, lotion on the feet, because that's something that almost nobody does. And some of them said, I can't reach my feet, but this is a very good one. Everybody can put cream on their feet if they do what it is on the picture. And also the patient is instructed in complication. What is the term if you don't do what I said to you, what I told you? And in self-care, of course, and in footwear, we also educate them a lot. It's very important that you have the right foot care. I will come into that later. After the examination, we defined our patient into 4 category groups, risk groups. As you can see, this is the risk group 1. There's no lack of sensation. There's no blood reduction. So those patients won't get anything. They have to pay themselves. And the risk group 2, they have neuropathy. There's no blood. And they have some misalignment, calluses, corns, maybe ingrown toenails, and maybe they also have some fall position in their feet. And then they will get 4 times a year with the treatment. Risk group 3, this is, as you can see, the thing is they have a burned Charcot, they have had ulcers, and those patients will get 8 times a year with the risk. And then we have the risk group 4. That is when you have ulcers, you have all the treatment that you can get for a year, or you need. This is, as I told you before, this examination is registered in a central database and used for the healthcare professionals for treatment of the patient. And it goes directly to the practitioner doctor, so he knows everything about this. So what do we do? Other preventive treatments. As you can see, we take what it says, removing calluses, removing corns, straighten ingrown toenails, straighten alignments, and relieve minor complication. And I'll just go through them. Calluses, as you can see, that's hard skin. It's going to be taken away. What it does, it makes the skin on the feet unflexible. It makes them hard, and you can that can get ulcers underneath it if it is not being treated. So it has to be taken away, as you can see here. And the calluses is also obtained of those places, as you saw before, and the causes of it. That's the position of the feet, as I told you. It can be because of overweight, it can be the shoes, and it can also be skin disorders. And then we have the corn. The corn can also occur everywhere, between the toes, under the toes, above the toes, and it's also because of clavy, we also call it. And that's it's also to be treated, because this one can really make an ulcer as easy as nothing if you don't take it away. And you can prevent that from coming by doing minor facilities, and you can cut that out. It's very easy to do. You don't need a lot of stuff to do that. I will show you tomorrow, I will show you something about that. And then you have the ingrown toenails, which really can be a huge problem. 1 year ago, I was here. Last year in December, I was in Ahmedabad, and there is one man in India walking around with a brace on his toe. I don't know, I haven't seen him since, but I hope he's fine. But it's easy to do, and you can all learn it. And you should, because it's so effective. I would show. That is what you do. And you bring the nail up in the right position again. And it helps immediately. It takes away the pain, it takes away the pressure on the skin. It's really good. And then we talked about the base of the feet is composed by 26 bones. Ligaments, muscles, and nerves, and it has to be playing together in a perfect harmony. And if there's any position of the feet that is not working right, it has an influence on the whole body, and especially on the feet. And that is also something that we do a lot of in Denmark, the podiatrist, making insoles. And we do it, we make them for the patient. Every insole is different. It's making directly to this patient. As I told you before, there's a minor facilities we can do for taking away corns. You can also put this one underneath the skin, underneath the feet. You can also have corns underneath your feet, and if it's really bad, you can use that immediately, and it's really working. The common spot for ulcers, I've just pointed them in. As I told you before, take away the hard skin. You really have to. That's the first thing. Take away the hard skin. Now I want to show you some patients I had. I worked in a hospital in Denmark, Gentofte, in a diabetic session. And this was a male who came in, as you can see, the 4th of March. It was last year, but anyway, I still see him, and he hasn't got anything like that. At that time, he has never been to a podiatrist. He was only going at home. He has orthopedic shoes, so that was not so good that he has developed something like that. But he has a lot of hard skin, and you can see what happens if you don't take away the hard skin. Underneath the hard skin, there can be a blood, and it can be really infected if you don't do anything about it. So really take the hard skin away. This is also one of my patients. I've known him for 30 years, and he has not been good to his diabetes. And that's why he almost, as you can see, he only have one toe left on the right foot. On the left foot, he still has all his toes, but he lost his heel half a year ago. I still treat him, and it's getting much better. This is one of my patients as well. It's a Shakofu, and as we all know, this is not seen very often, thank God for that, but we see it. and it has to be treated. It has to be treated with the right shoes, with the right insoles. And if you find something like, you have to, the patient has to sit down immediately. It's not to be walked on, because then it can get a lot worse. This one is a slide that I think is very nice, because it shows the diabetic neuropathy, how effective it is on the rest of the foot on the body. And I have now illustrated the diabetic foot treatment in the Danish health system. And as you can see and be able to see, the diabetic people is in good hands in Denmark. And hopefully I will be able to treat those for 20 years more. So thank you very much for listening.
Thank you, Lona, for that interesting talk. It's really nice to note how meticulous you are in treating patients.
Thank you. You can come tomorrow and ask me. The insoles is a very important part of that. If you really have a patient who has a lot of calluses under your feet, of course you should make an insole. You go into the footwear. What I can see here in India, you have a problem because all of you are wearing sandals. And that's really a problem for what I see, because in my opinion, the most important thing to treat this diabetic patient with the fall position is that you have a shoe that has a hard and a strong back on the shoes. And I can't find any. I've been looking around in Trivandrum, and I can't find shoes like that. I've been to the hospital, in JPEF hospital, and they have shoes there that have been making outside. And also the sandals. You can make sandals, but you really have to look into the heel cap, that is strong, and it's keeping the heel in the right position. I brought a sandal from Denmark who has that, so I can show you, and maybe somebody who knows somebody who makes shoes can see that and can do something, because that is exactly what you need here. I hope tomorrow I will show you the pictures of the patient that I treated here, and I will tell you about what I've done and what I told them to do. And I brought a lot of stuff, so hopefully we have a patient tomorrow.